Hello, good evening, doctors. Myself, Dr. Veena Venkatesh from Ajanta Pharma, working as General Manager and taking care of a medical services department. Today we have with us, on the behalf of Ajanta Pharma, I welcome each and everyone for this today's scientific session. Today's the session would be place of statin and clopidogrel when approaching ASCVD. Today we are fortunate that we have with us Dr. Professor Rabindra Chakraborty from Kolkata, and I am very much privileged to introduce him to the audience. Uh, Professor Dr. Rabindranath Chakraborty. He is a gold medalist. He is a senior vice chairman and director, senior consultant, interventional cardiologist, and electrophysiologist, medical group of hospitals. As far as the qualification goes, he is MD DM from Chandigarh, and he has many fellowships. FRCP from London, Glasgow, Ireland, FACC from USA, and so on. He is a very eminent cardiologist, electrophysiologist. Formerly, he was a regional director and head of cardiology, Apollo Hospitals, former senior consultant cardiologist and head of electrophysiology, Apollo Hospital, Hyderabad. Formerly, he was consultant cardiologist, electrophysiologist, Hull Royal Infirmary and Castle Hill Hospital at England, UK. And he has, in his credit, there are more than 10 medals in the academic career. He's been as the best medical graduate of Calcutta University. He has many research publications, more than 70 publications in international journals. He's been the principal investigator of many international trials on healthcare from the year 2000 onwards. He's been the author of the book ECG for General Physicians, writer of chapters on cardiology topics in many rocks, and former president of Indian Society of Electrophysiology India, editor of Journal of Indian Society of Electrophysiology of India, member of the advisory board of the Indian Heart Journal, faculty in international conferences and live workshops on interventional cardiology, governing council member of Indian College of Cardiology, executive member of Cardiological Society of India, executive member of the Indian Medical Association, West Bengal, and all. With this, a very brief introduction of his, I would like to hand over this session to Sir, and then he will take through us to the topic allotted. Later on, there will be a question answer session which will be handled by Sir. Sir, over to you, please.
Yeah, good evening, everybody. Thank you, Dr. Veena, for nice introduction. I'm really privileged and honored to be here. I personally thank Mr. Tripathi of Ajanta Pharma to invite me, who actually repeatedly was very sincere, very hardworking, and requested me to participate in this important meeting. As we all know that we are actually going through an unprecedented crisis all over the world, and India is no exception. But at the same time, we being physicians and involved in patients' care, we need to look after our patients, and also we need to be updated about the development of various areas of medicine. And myself being cardiologist, I personally feel that we should always remain updated. As we all know that medicine is a subject which continues to change, continues to grow, and it is very important for the doctors, for the physicians to keep themselves updated. So even if the world is almost closed, there's a lockdown in the entire world, but we, the doctors, are trying to educate ourselves and to our colleagues, and therefore I'm really grateful to Ajanta Pharma for such a unique opportunity, which sort of I am sharing with my colleagues in the entire country. This evening, we're going to talk on something very important. As we all know, this year, American College of Cardiology could not be organized the way it is being organized for so many years. Because of the lockdown, United States decided to have this meeting, a kind of a virtual meeting. But at the same time, in the virtual meeting, people actually talked about science, talked about cardiology, talked about therapy, and talked about certain drugs which are important for treatment of cardiovascular patients. This evening, we are going to share my views with some scientific experience, as well as some highlights from American College of Cardiology to all my colleagues across the country. And the topic is place for statin and clopidogrel when approaching atherosclerotic cardiovascular disease and highlights from American College of Cardiology. We all know that cardiovascular disease is a leading cause of death across the world. But it is important for us to also to know that modifiable risk factors are the primary driver for first cardiovascular events. Up to 90% of patients of cardiovascular disease or atherosclerotic cardiovascular disease and atherothrombotic disease, they take drugs like antiplatelet drugs, lipid-lowering drugs, antihypertensive agents, with or without anti-ischemic medication. I also need to mention that about 30% of these population, they also have associated diabetes mellitus, and which is an important component of the planning of treatment, of the long-term prognosis, as well as the outcome after therapeutic intervention, be it medical or drug-based therapy, or even catheter-based therapy or surgical therapy. In an acute coronary syndrome, thrombus formation occurs under conditions of high shear stress and is principally driven by platelet aggregation. Somebody was talking to me about, I just gave a talk about COVID-19 infection and acute coronary syndrome. You'll be surprised that many patients may not have significant coronary artery disease, but there are plaques being embedded in the coronary artery, which was already there in a pre-existing plaque, but may not be very significant. But this infection actually made this plaque very unstable, causing plaque rupture, leading to thrombus formation, resulting into ST segment elevation myocardial infarction. So high stress or even mechanical shear stress can also be a cause of thrombus formation driven by platelet aggregation. Therefore, antiplatelet therapy is important part of treatment for acute coronary syndrome together with lipid-lowering drugs. This dominance of platelet aggregation during intracoronary thrombus formation reflects the dramatic effects that antiplatelet therapy have on clinical outcome. It is very important, and also together with that, we also need to keep the patient on other medication like drugs for hypertension, diabetes, ischemic heart disease, and lipid-lowering drugs. So important for us, so the most important component of treatment of cardiovascular disease like atherosclerotic cardiovascular disease is prevention. And this prevention basically in three fronts. These fronts are, we know the mechanism could be inflammation, and degeneration. So the three fronts we have to address is endothelium of the coronary artery and clotting coagulation, which where the platelet and other factors are involved, and autonomic nervous system because of inflammation and stress can actually precipitate an acute coronary syndrome, so that needs to be addressed. And this is a very interesting slide, which shows very clearly that the atherosclerotic cardiovascular disease is basically an interplay of a genetic variability and their adaptive or maladaptive response to environment. For example, some people may be genetically susceptible, and because of exposure to some untoward circumstances, untoward environment, they tend to get complicated, leading into acute coronary syndrome. But I have to say that they may also have an associated lipid abnormality. They may also have an associated diabetes, hypertension. Some of them could be smoker. Some of them may have obesity. Some of them may have sedentary lifestyle, lack of exercise. So complication of these factors together with maladaptive response or in an environment to those people who are otherwise genetically susceptible can complicate the disease process for a longer period of time, leading into atherosclerotic heart disease. We need to understand that atherosclerotic heart disease is a degenerative disease, but primarily there is a very small degree of inflammation which remains unnoticed and perhaps continues to be there inside our body for a very long period of time, maybe for 10 years or even 20 years. We also need to understand that if someone gets heart attack today, it does not necessarily mean that the disease happened today. Disease might have happened many, many years ago. So when you talk about treatment, particularly drugs like lipid-lowering drugs, we need to understand that drug has to be given or has to be prescribed long ahead or long before the disease happens. That is what is important. And that is why this is very important. So in the preventive strategy of unstable coronary artery disease, we should address these fronts, which are primarily, let us say, lifestyle modification. A lifestyle modification means smoking cessation, diet and weight optimization and exercise. Together with that, patients also should continue to take antihypertensive drugs like ACE inhibitors, ARBs, amlodipine, and other drugs of whatever has been recommended. They also need to have lipid-lowering drugs like statin primarily. A small group of patients may also require ezetimibe and PCSK9 inhibitors. And in addition to that, some patients, especially those patients who are prone to get acute coronary syndrome or having a very high risk group of developing some kind of atherothrombotic disease, they should remain on antithrombotic drugs like aspirin, P2Y12 inhibitors like clopidogrel, and a small group of patients who remain on who has got atrial fibrillation or cardiorhythmia may also require oral anticoagulants. So this evening, I'm going to talk only these two areas. So the threshold of therapy continues from a continuous treatment from primary to secondary prevention. So if we treat a patient, we should not forget that treatment starts much before the disease starts. That is the unique character that cardiovascular, atherosclerotic cardiovascular disease has. I repeat it again, the treatment starts much before the disease starts, which means when you see the disease, when the patient is symptomatic, disease is actually there maybe many years ago. So you need to recognize that, you need to understand that, and you need to commence the treatment at that point of time, maybe 20 years ahead of time. That is something called primary prevention. Secondary prevention is if someone has an event, then they should continue to take the medication as been prescribed to them. So how do we modify cardiovascular risk? The options are lifestyle, as I discussed, glycemic control for diabetes, and blood pressure control for hypertension, and of course, management of dyslipidemia and platelet inhibition. This evening, I'm going to focus on management of dyslipidemia and platelet inhibition to share my views and certain data from the literature together with the points which has been focused and discussed this year in American College of Cardiology virtual conference. So coming back to the statin treatment, we all know that statin have a long-term benefits in patients with coronary artery disease and acute coronary syndrome. The benefits of statin in acute coronary syndrome begin early, before substantial lipid lowering has occurred, suggesting pleiotropic response or pleiotropic effects of statin. So there could be some degree of inflammation, and today we know that statin, in addition to lipid lowering effect, may also has anti-inflammatory effect. These might include anti-inflammatory effects, improvement of endothelial functions, decrease of oxidative stress, or inhibition of thrombogenic process. So, or thrombogenic response, which essentially means that if you give a good dose of statin right from very early stage and at the early stage of the disease process, then you can actually maintain the integrity of the endothelium. And if you maintain the integrity of the endothelium, the chances of disruption of the endothelium leading into advancement of the atherosclerotic process ceases or slows down considerably. As furthermore, statin also causes anti-inflammatory effect. Therefore, again, that reduces the process of atherosclerosis. And as there is a less atherosclerotic process, the plaque which was there, the plaque becomes much more stable plaque. It doesn't remain unstable plaque. And if the plaque is stable, organized, the chances of a rupture to that plaque is very less. So sometimes we call the thin cap fibrous plaque is very uncommon if we protect them well in advance with drugs like lipid lowering drugs like statin, which is very important for us to understand. So statins were beneficial when pre-treatment was started from 7 days just before PCI, which is a fantastic data which was published in JACC sometime 9 years ago. That if you know that you're planning to do some intervention, you start the patient on lipid lowering drug at least a week before, you know the long-term result of that patient will remain very well. But when you decide that how we are going to treat this patient with lipid lowering drug, the question is that anybody can ask the question that whether or not everybody would require lipid lowering drugs, everybody would require the same dosage of lipid lowering drug, then one has to create a kind of a risk stratification. That risk stratification is important. So if you have to calculate about 10 years atherosclerotic cardiovascular risk. Once you calculate that, You have to categorize them as low risk group, which means 0 to less than 5%, 5% to 7.5% borderline risk, which means that if 100 people are being followed for 10 years, 5 of them may develop heart disease in 10 years' time. So intermediate risk, when the risk goes from 7.5 to 20% and beyond 20% is high risk individual. So clinician, so if it's a low risk group of patients, let us say 0 to less than 5% of low risk, which I'll talk a little later in detail, then you do not need to give statin therapy. So be very clear. We do not prescribe atorvastatin or rosuvastatin to every individual, assuming that he or she will get a heart disease patient or atherosclerotic cardiovascular patient at some stage. No, if we estimate and calculate the risk, which is less than 5%, then we do not sort of prescribe drugs like atorvastatin or rosuvastatin. We ask them and advise them to continue lifestyle modification, which means cessation of smoking, modification of diet, maintaining of blood pressure, maintaining of blood sugar, regular walking, and avoid the sedentary lifestyle. These are the important things which I want us to remember. But if you think that the risk is higher than that, like 5% to 7.5%, then add or maybe 7.5 to 20% or less than 20%, then we need to interact with the doctors. The doctors need to interact with the patients, and then we need to discuss about considering the risk enhancing factors and net benefit of therapy. If we are sure that the discussion goes well and the patient is convinced that they need to take care of themselves on a long-term basis, then again they can continue on lifestyle modification. We do not go straight for atorvastatin prescription. But if there is an uncertainty, or if there is a further more sort of complication that his compliance is not good, then we have to again consider today, at least in 2020, you can actually do in some group of patients when you think that it's maybe a high borderline risk or intermediate risk. For example, somebody, a commercial pilot, hire a doctor, professional, or maybe an engineer or important executive for a company. For these group of patients, we can actually consider coronary artery calcification. If the coronary artery calcium score is high, then we can think of giving lipid-lowering drugs. Or if the coronary artery calcium score is low, we can actually continue or advise them to continue on lifestyle modification. Clearly, those patients who are at a high risk means the risk is more than 20%. It means that out of 100 patients, more than 20 of them will get atherosclerotic cardiovascular disease in 10 years' time. There is no point of going for only lifestyle modification. Lifestyle modification need to be continued, but along with lipid-lowering drugs like atorvastatin, or in some cases, you can also prescribe rosuvastatin. And that is very important for us. So this slide is very important, and it tells us a lot of things that what would be the kind of risk stratification or kind of a triaging of patients of atherosclerotic cardiovascular disease. So to summarize, in atherosclerotic cardiovascular disease, we need to have family history of premature atherosclerotic cardiovascular disease, primary hypercholesterolemia. You have to assess for metabolic syndrome, other conditions like chronic kidney disease, chronic inflammatory conditions, ethnicity like South Asian ancestry has got a very higher incidence of atherosclerotic heart disease, lipid biomarkers, and sometimes LP, small little a, HSCRP, and ankle brachial index is very important. And risk enhancers, the presence should prompt reclassification to higher risk group. Coronary artery calcium measurements can also help guide management decision in borderline and intermediate patients, as I discussed earlier. So that is very, very important. Same thing, again and again, I'm trying to emphasize that how one should stratify the risk, family history, primary hyperlipidemia. You have to consider about low density lipoprotein cholesterol. If it is more than 160, 180, one has to be really, really careful about it. Non-high density lipoprotein also need to be considered. Metabolic syndrome, 3 or more of the following, like increased waist circumference, fasting triglyceride more than 150, hypertension, elevated blood sugar, low high density lipoprotein, and chronic kidney disease sometimes important. Chronic inflammatory condition and high risk ethnicity and other parameters as I discussed. ACC and AHA lipid guidelines clearly says that personalized care to prevent cardiovascular disease. In addition to heart healthy lifestyle, statins are the foundation of lipid management. I repeat, lifestyle modification has to be done, but American College of Cardiology and American Heart Association lipid guidelines clearly mentions that lipid or statin therapy are the foundation of lipid management. Atherosclerosis begins in the first few decades of life with a fatty streak, which may not be picked up by angiography or even by sort of, with any other imaging system, maybe a very high definition HRCT or perhaps a cardiac MRI may be able to pick up, but I'm not quite certain. But it begins with a high fatty streak in which lipoprotein are deposited, very, very early stage. If a patient age is 20 to 75 and has LDL cholesterol more than 190, without any hesitation, we should commence the patient on high intensity statin therapy right away. The question is, what do you mean by high intensity statin therapy? I will talk a little later. So the preventive therapy in different patient subgroup, like if the patient has severe hypercholesterolemia, diabetes mellitus, adult age 40 to 75 with LDL-C level is 70 to 189 milligram, children and young adult of very familial hyperlipidemia and other abnormalities, ethnicity, sometimes with chronic kidney disease, sometimes with chronic inflammatory disease and hypertension and other diseases. We also need to remember that South Asian community like ourselves have higher atherosclerotic cardiovascular risk than East Asian countries, or even continental, or even other communities. South Asian men have similar coronary artery score calcium burden to non-Hispanic white men, but higher coronary artery calcium compared to the blacks and Latinos. South Asian women have a similar coronary artery calcium score compared with other ethnic and racial groups. So coronary artery calcium scoring is again a very important factor today for the commencement of therapy like statin in patients of atherosclerotic cardiovascular disease. And this slide shows that you can have a lesion like this, type 2 lesions, just as microphages forming cell. This is the coronary artery calcium scoring chart. Type 3, little deposition, type 4 atheroma, type 5 really, really deep, and type 6 very complicated lesion. So this is the coronary calcification occurs almost exclusively in atherosclerotic process. So if your CT angiogram shows coronary calcium, it means that this particular gentleman or lady has got atherosclerotic cardiovascular disease, and no doubt about that. So this is very important. So this slide is very important. This is a European kind of a guideline. If LDL-C is the primary target, treatment of goals for LDL-C determined according to the cardiovascular disease risk, as I mentioned earlier. If you find that your patient is at low risk and score is less than 1%, then probably you can just do what is called the lifestyle modification. Moderate, score more than 1 to 5%, young patient with diabetes mellitus or diabetes mellitus and other risk factors, you need to think about it, and you need to reduce the cholesterol to a level which is about 100 milligram per deciliter, about LDL goal. High risk individual having markedly elevated risk factors with high cholesterol, high LDL more than 190, hypertension, family history, moderate chronic kidney disease, diabetes, any of these for more than 10 years, then the target LDL should be less than 70 milligram per deciliter. So this is the target which you need to have. And then if you have very high risk individual, score is more than 10% with established atherosclerotic cardiovascular disease, either by clinical examination, diagnosis, or by imaging diagnosis, with a family history, severe chronic kidney disease, diabetes mellitus, and one target organ damage, at least one, then the target LDL cholesterol should be 55 or less than 55. If it's a very high, very, very high risk, which means that in addition to all these, patients actually has a secondary event, like had a heart attack, or had a bypass surgery, or had an angioplasty, and you have got all the other risk factors together, like smoking, diabetes, hypertension, family history, chronic kidney disease, and if these are together, then they are very, very high risk, and then in that case, the target should be 40 milligram per deciliter, and that is what is important. This is a very interesting slide, has been published by European group, and makes a lot of sense. So this is a kind of recommendation by our society. We got a society of lipid association in India by Dr. Raman Puri, and I'm also a member of this group, and I have participated in his meeting and contributed in literature about a recommendation. This is the kind of recommendation that we suggested, that in a very high risk patient, this will be our target. More than 3 high risk, your high risk group, then you've got a atherosclerotic cardiovascular risk factors. Look for other risk factors. Low risk, basically the same. There is not much of difference, but the intensity of statin therapy depends upon the risk stratification, and accordingly you have to calculate and you have to prescribe the patient. When you talk about high risk individual or high intensity statin therapy, usually we start with 80 milligram atorvastatin or 40 milligram rosuvastatin, and then you monitor the cholesterol, particularly the LDL level. And if the LDL goes down, then we try to reduce the dose and see at what level the LDL remains the goal that we are trying to achieve. The dose at which, because there is so much variable in a patient, every patient behaves in a very different manner. One has to understand that. So depending upon that particular patient, if we find that the dose requirement is less, but whatever may be the dose, either 20 milligram atorvastatin or 10 milligram rosuvastatin, if we find that patient has achieved the required goal of LDL and there are other parameters, then we are quite happy to continue the same dose for a longer period of time. Please do remember that if once you assess that patient belongs to some kind of risk, be it moderate risk, high risk or very high risk, never ever stop the lipid lowering agent. So you need to titrate the dose and find at what level the actual goal of LDL has been achieved. Once it has been achieved, continue to remain on the same dose. But at the same time, if the same patient on that dosage, is going for some procedure, for example, that maybe one of the lesion was tight and patient required some intervention, either by angioplasty or surgical intervention, then during that time, you have to intensify the dose to the next level. For example, somebody on 20 milligram, you have to go for 40 milligram. Somebody on 40 milligram, you have to go for 80 milligram. Or somebody in acute event, you have to go straight to 80 milligram of atorvastatin, and then again come down slowly to the dose which would be ideal to achieve the kind of level. Of course, that belongs to something called secondary prevention, a different approach. So that is the kind of a general guideline to decide about your dosage and to decide about the risk stratification in Indian patients. So we have to again calculate the lifetime atherosclerotic cardiovascular risks in all low risk individuals. We also need to remember that there is a spectrum. It's a longitudinal kind of study, a longitudinal observation, longitudinal follow-up, because these patients today, whatever, like somebody is 20 years old, and we know we are calculating that what is going to happen in 40 years. But when the same person reaches 40 years, then actually the same person low risk may go up to moderate risk. So the risk also, we need to recalculate the risk with time, maybe every 5 years or every 10 years. We need to recalculate the risk and re-prescribe the statin depending upon the target level or the cholesterol level to be achievable or to be achieved at that point of time. The dose had to be readjusted and after recalculation of the risk. So please remember that, and it's very important, very essential for us to understand it. So as I said, the primary target in a very high risk group could be 50 milligram or less. Statins are primary modality of reducing LDL-C, except in high risk and very high risk group, start with moderate intensity, something like 20 milligram of atorvastatin or maybe 10 milligram of rosuvastatin, and titrate up as tolerated by the person. Many patients may not be able to tolerate because it causes a lot of myalgia. There is also some kind of hepatic side effect, which I'm going to talk a little bit. There may be some little bit of neurological problem one has to understand. So these are the little bits and pieces one has to remember, but they are not very high. But muscle pain at times, it really causes problem. So we need to counsel the patient, we need to talk to the patient. So depending upon the patient's tolerance and the risk factor, we have to create a target. And depending upon the target, we titrate the dose and achieve the target and stay at the same dose. Discuss the risk and benefit of treatment with the patients and relatives. lipid profile should be checked at the time of diagnosis and every 3 to 6 months treatment. Once it is settled, then there is no need to sort of check every 3 months. You can probably check every 6 months. And once it is very stable, patient is completely asymptomatic. Maybe I would say once in a year, or maybe between 6 months to 1 year. That is perfect. So LDL-C is important. But if the patient, after giving maximum statin dose, the cholesterol doesn't come down, as it happens in conditions like familial hyperlipidemia, in a small group of patients, particularly those patients who got associated diabetes and smoking, is very difficult, very tough, and very stressful life. Then you may have to add other drugs, something like fibrate or even ezetimibe. We good old days we used to give bile acid sequestrant, but this progressively prescription of these drugs is slowly coming down. These drugs should be used in patients with statin intolerance. Lifestyle modification should be continued, as I say. When we talk about LDL-C, we also must not forget something called non-HDL-C. Non-HDL-C means what? Non-HDL-C means total cholesterol minus high density cholesterol. It includes all atherogenic particles. Remember, LDL is an obnoxious particle, no doubt about that. But VLDL remnant, chylomicrons, that can also has atherogenic particle. They are known to cause atherogenic process. It may not be directly, but somehow it stimulates the process of atherosclerosis. Intermediate density lipoprotein, LDL-C, especially or LDL-C and lipoprotein little in combination, can be hazardous in young individuals. Measurements of non-HDL-C does not require fasting blood sample. Please remember that. Many people, and also remember, those patients who are on regular dosage of the drug therapy, you need not be very arrogant about keeping the patient fasting, because that can be the beginning. Once you start prescribing and keep the patient under follow-up, then you know that how the patient is responding. So it is important to also to consider non-HDL-C. Statins are effective agents for decreasing levels of non-HDL-C as well. If LDL-C is also has to be monitored. Now coming to triglyceride. Triglyceride is again important. Triglyceride level should be treated. Patient should be evaluated for possible secondary cause of hypertriglyceridemia. There are many causes of hypertriglyceridemia. I also need to mention that there are other causes of high cholesterol as well. For example, hypothyroidism. Hypothyroidism can cause high level of cholesterol. One has to exclude these conditions, and then only you commence your treatment. But goal of triglyceride level, triglycerides somehow in women, more so in Indian women and in South Asian, particularly Indian population, has been found to have some kind of risk of atherosclerotic cardiovascular disease in association with high triglyceride level. So the triglyceride level should be less than 150 milligram, preferably less than 100, but I would say about 100 to 110 would be fine. If it is there, then nothing to be worried about. Triglyceride directly doesn't cause atherosclerosis. It gets converted. It enhances the process of atherosclerosis when you got a high level of triglyceride, because that is the raw material that the body has, which can quickly get synthesized to different other atherogenic particles leading into atherosclerotic process. So the targets of therapy, again, lifestyle modification for triglyceride. Targets of therapy for triglyceride, again, lifestyle modification. Lifestyle modification can actually help to reduce triglyceride level by 50%. Regular brisk walking is very helpful. Dietary modification is extremely helpful. Achieving non-HDL goal is also important, because if you can reduce the HDL-C, eventually actually you're reducing triglyceride, because that is what is the mathematical formula. Statins are the treatment of choice to achieve target level of triglyceride level. Even the statin, like atorvastatin, even rosuvastatin, they can actually reduce the triglyceride. If you find that in your patient, the cholesterol is high, so you are giving atorvastatin, but triglyceride is, let us say, 160 or 170. You need not give a drug called fenofibrate to reduce triglyceride. Just see how the patient responds to the treatment as you prescribed by statin like atorvastatin. Many of these patients, in many of these patients, the atorvastatin therapy may actually reduce the triglyceride level. So the HDL-C, as I said, pharmacotherapy aimed at raising HDL-C does not appear to improve. There are plenty of studies. A whole lot of literature was there on HDL-C improvement, but none of those literature did show any support of using of drug like niacin and so many things to increase HDL level. Physiological measures that include perhaps exercise may increase HDL-C, and a bit of other non-lifestyle modification may have some role. Changes in understanding of HDL physiology may lead to therapies targeting qualitative modification of HDL in future. This is one slide I would like to share about statin and diabetes. For diabetic group of patients, statin needs very special emphasis, and that needs to be remembered. I already talked about statin intolerance, so I'm not going to discuss again. One has to be aware of that. Incidence is around 10%, but true incidence may be low. But in the monitoring of CK, it's probably helpful. If you find patients getting severe pain, as it happens in rosuvastatin, at times with high dose of atorvastatin, you will reduce the dose and explain to the patient and see that how the patient tolerates. Or you can change from from rosuvastatin to atorvastatin. That also helps. Similarly, hepatotoxicity, as such, not very high. Hepatotoxic incidence is, I would say, not less than more than 3%. There may be mild elevation of hepatic enzyme. One is to monitor the hepatic enzyme. If you find that hepatic transferase, the liver transferase has gone 3 times beyond the level at which you commence the therapy, then you should probably hold the drug or reduce the dosage. But sometimes patients with non-alcoholic steatohepatosis, there's a reservation of statin therapy. No, statin may actually be helpful in non-alcoholic steatohepatosis. This year in ACC 2020 in Chicago, there's some very important information came showing that atorvastatin reduces the total events overall and across the vascular bed. And this is a trial called Sparkle trial, and clearly shown the vascular, cerebrovascular, coronary, and peripheral. All the incidents are significantly reduced because atorvastatin prevented more than twice the number of total events than first event, with reductions in all vascular bed. Total event reduction is a useful metric to gauge the atorvastatin efficacy after recent stroke or TIA. So these are the kind of parameters by which you can not only the cholesterol level, you can actually see the events like cardiac event, peripheral vascular event, cerebrovascular event. The total vascular event has considerably came down once the patient is on atorvastatin therapy. That's what we find in our everyday practice. In the same meeting, they also talked about lipid management in acute coronary syndrome. In acute coronary syndrome, we have to give a bit of higher dose, and LDL-C goal has to be achieved with a high dose, high level, or high dose, high intensity dose of statin like atorvastatin 80 milligram. Now we come to antithrombotic treatment in patients with atherothrombotic atherosclerotic artery. It is well established. For years together, we know that clopidogrel 600 milligram loading dose and 75 milligram daily dose to be prescribed in patients who is undergoing PCI. Of late, we're also getting ticagrelor and prasugrel. And there are other drugs which, of course, we use like GP2B or other condition in more of an acute setup. But clopidogrel is an established a class 1 indication, and that's how the clopidogrel, it like aspirin, it works and is a COX-1 inhibitor. It blocks the thromboxane A2 receptor. On the other hand, the clopidogrel blocks the P2Y12 receptors, which basically add ADP-dependent receptors. And as it blocks, the platelet loses its ability to aggregate properly, and therefore there is no thrombus formation. That is the basic mechanism by which the clopidogrel and aspirin, they work together. In an acute situation, you need to give both, or in a high-risk individual, you need to give both aspirin and clopidogrel together, so that the platelet can be blocked at 2 major receptors in order to prevent the platelet aggregation to initiate the thrombotic process. The question is that how long you should prescribe. If the patient is asymptomatic, completely asymptomatic, and is well under control, diabetes, hypertension, everything is under control, patient is no symptom at all, and the patient is out, but otherwise is a known case of stable coronary artery disease, I must make it clear that we need not give dual antiplatelet therapy in this group of patients. It's very clear. But those patients who require intervention, like angioplasty, and these days we are actually routinely use drug-eluting stent. We do not use bare metals. Very. I don't even remember for during my last 5 years or 10 years, 5 years, I would say I probably never used any bare metal stent. So drug-eluting stent is the drug, and you have to assess the bleeding risk. If you find that chances of bleeding is low, then you continue this dual antiplatelet therapy at least for 6 months. If you find the chances of bleeding is high, for example, somebody having some known acid peptic disease was treated earlier, or somebody having some kind of sort of risk, like not exactly the recent cerebrovascular accident, but like a very uncontrolled hypertension, for example, there is a risk involved. So if you find there's a risk of having major bleeding or minor bleeding, then you reduce the dosage of dual antiplatelet therapy only for 3 months. Don't go beyond that. And the same is BRS is gone. We don't use BRS at all. But if you find in ACS, acute coronary syndrome, when patient goes for angioplasty, again you stratify them in high risk and low risk. If there is a low risk or no high bleeding risk, you continue to give dual antiplatelet drug for at least 1 year. That's a conventional treatment. That's what I do myself. Recently, there's a trial came, which is called with a Medtronic stent called Onyx stent. They recommended that you can probably give dual antiplatelet therapy for a shorter duration of time. However, if you find the risk is higher, as you calculate from your clinical judgment, the 6-month dual antiplatelet therapy in acute coronary syndrome may be continued for at least 6 months. That is a recommendation. And the same thing is coming here. But what is important for all of us to understand, that when you give antithrombotic treatment, and should you decide to switch over from, say, prasugrel to clopidogrel or ticagrelor to clopidogrel, when you switch over, you reload. In an acute setting, you always reload the patient, reload. Do not assume that patient was getting one dose earlier, one drug earlier. Now, no need, you can start a smaller dose. You have to reload the patient. It's extremely important. But in chronic setting, what you do, if the patient is on prasugrel and then you want to switch over to clopidogrel, you have to just give a 24-hour last clopidogrel dose. After that, clopidogrel dose 75 milligram 4 times daily for 1 day, and then you switch over to once daily. And same is true for ticagrelor. 24 hours after the last clopidogrel dose, you give clopidogrel 600 milligram. They have to load the patient, and then you continue with 75 milligram. That is the kind of approach one should have. And antithrombotic treatment, this is a kind of a duration, what I said, the certain risk, again, the scoring called precise DAPT scoring, like you calculate the hemoglobin, the white cell count, age of the patient, creatinine clearance, prior bleeding history, and this is the kind of score that you achieve. If you find in an acute coronary syndrome or at the time of coronary stenting, if you find the score is more than 25, then you give short DAPT. If the score is less than 25, then you give standard or long DAPT. Or in a chronic situation, after 12 months of uneventful DAPT, if you find that this is the kind of score that one has to understand, look for the age of the patient and see history of smoking, diabetes, heart attack during stenting or prior PCI, this kind of thing. If the score is more than 2, then give longer DAPT. Score is less than 2, then the standard DAPT. This is a kind of a score which is extremely useful in the clinical practice. So, to pre-treat or not to pre-treat, STEMI ESC guideline loading dose of clopidogrel has to be given 600 milligram and followed by what I do after 600 milligram, we do 75 milligram twice daily during in hospital, and after discharge you continue 150 milligram clopidogrel and aspirin, something like 75 milligram, and then in the next follow-up after 7 days, 10 days, I switch over to 1 tablet 75 milligram of clopidogrel and aspirin 75 milligram. This is the kind of recommendation. So the individualization important for duration of dual antiplatelet therapy. Patient-related factors need to be considered. Patients with stable coronary artery disease, patients with history of bleeding, with high risk of bleeding, less than 12 months, anatomical related factors like short lesion, single vessel disease, less than 12 months. Stent is a short stent or second generation or third generation stent. You give a short duration DAPT. Like as I said, that Onyx stent or a new generation stent, you do not give for a longer period of time. But in an older generation, stent or long lesion, left mainstem disease, bifurcation disease, having diabetes, renal dysfunction, heart failure, and patient presenting with STEMI, associated peripheral vascular disease, associated extensive atherosclerotic disease, you need to give dual antiplatelet therapy for a longer period of time, maybe more than 12 months, and maybe at times for 2 years. Optimal DAPT duration depends upon the clinical scenario, as I said. Mostly, stable patient less than 6 months, in an acute setup up to 6 months, and mostly you close after 12 months. In a very high risk individual, you have to continue beyond 12 months, maybe for 2 years. This is a kind of after scoring called precise DAPT score and DAPT score calculation. This is a fantastic study by Dr. Angelio, and is very nice for our clinical application. This year, again in Chicago meeting, people talked about it. Differential effects of dual antiplatelet therapy in patients with acute coronary syndrome. Optimum antiplatelet strategy following revascularization in coronary bypass graft remains controversial. The current study evaluated the long-term clinical outcome, and this study has found that among ACS patients who underwent bypass surgery, the use of DAPT was associated with lower cardiac mortality than the use of single antiplatelet drug. So that is important. So in an acute setup or a high-risk individual going for bypass surgery, dual antiplatelet therapy is important. Optimum antiplatelet strategy following revascularization with bypass surgery is controversial, but as I said, that is what exactly it is. Efficacy of clopidogrel compared with more potent drug is subject to debate. People think that the newer generation is very superior, but clopidogrel is a time-tested drug. We have been using it for many years. Of course, the newer drug like ticagrelor has some advantage, no doubt about that, because it is a very short duration action, especially for those patients. It is reversibly bound with the receptors. Therefore, it is very easy to get back to the normal situation. So, somebody is going for bypass surgery, maybe ticagrelor has an advantage, unlike prasugrel and clopidogrel. But prasugrel again is a good drug, especially in a very high risk individual. That is my personal experience. But I have been using clopidogrel for many years. It is a good drug and is a time-tested drug. In patients undergoing primary PCI with the normal function, with a clopidogrel resulted in less bleeding and no difference in net clinical benefit. Somehow, if you find in your practice or in your case that the patient has a higher bleeding risk, then out of these three, prasugrel, ticagrelor, and clopidogrel, I would rather recommend clopidogrel, because somehow clopidogrel, the chances of bleeding risk is less as compared to ticagrelor and prasugrel. Prasugrel has got a relatively higher bleeding risk, and same is true with ticagrelor, whereas clopidogrel that way is quite safe as of now. There is some data about body mass index and a comparison of clopidogrel and prasugrel in acute coronary syndrome. The platelet reactivity and in both prasugrel there is no difference between the clopidogrel and prasugrel, is almost the same. So to summarize, what is important, that patients in atherosclerotic cardiovascular disease leading into atherothrombotic cardiovascular disease, we need to have lifestyle intervention. We need to understand the lipid profile of the patient, lipoprotein, inflammation, metabolism, platelet coagulation. These 5 factors are basically interplay along with the gene and the background of the patient, leading into such atherosclerotic cardiovascular disease. So these 5 factors, lipoprotein, lipids, inflammation, metabolism, diabetes, inflammation, coagulation. And to overcome that, you need to give lipid-lowering drug. You need to give drugs for inflammation. We do not prescribe normally. Metabolism, of course, you have to give pre-diabetes, and drug, particularly HDL-2 inhibitors, are helpful. Platelet, give antiplatelet drug DAPT, which I spoke in detail. And in coagulation, in some situations like atrial fibrillation, you need to consider associated NOACs or other kind of things. Drugs, standard drugs, LDL, HDL, triglyceride, give your atorvastatin. It's a wonderful drug. Depending upon your risk stratification, you choose the dose and select the time and select the dose at which the patient, the target goal will be achieved. Similarly, for the platelet, as I said, you start with aspirin for a very stable patient, completely asymptomatic patient with high-risk individual. Patients who are high-risk, low-risk individual. For high-risk individual, you should go for both dual antiplatelet drug, no doubt about that. Patients having unstable angina, acute coronary syndrome need to be on dual antiplatelet therapy. You again stratify the risk, go for DAPT risk, and according to the DAPT risk, both in acute precise DAPT risk scoring, precise DAPT scoring, and DAPT scoring, you identify that what would be the dose required and for how long the drug has to be given. Clopidogrel is safe, especially in those individuals when you think that they have to be relatively higher bleeding risk, but it is not free from bleeding. That one has to remember. There is also bleeding because it irreversibly combined with the platelet. Trichloride has an advantage, especially for those patients going for intervention, but we do not know that whether patient would require intervention or eventually may go for bypass surgery. We also need to recognize that small group of patients may also require triple drugs. So this is my final slide. Again, I'm coming back to that for lipid thing, we need to have to set the goal. If low risk group, the goal is 116, moderate risk, goal is 100, high risk 70, very high risk 55, and very, very high risk is 40 milligram. Depending upon that, you have to select the drug, select the dose of the drug like atorvastatin or rosuvastatin, and maybe in combination with this HDL and PCSK2 inhibitors. And for antiplatelet drug, you have to follow the guideline recommendation, like ideally up to 12 months. In sometimes PCI with the drug not extend 12 months, and all others could be 12 months. A small group of patients may require 6 months. And in a very high risk group of patients, you can actually stop dual antiplatelet therapy after 3 months. With a new generation stent, with a newer drug modality, sometimes the dual antiplatelet therapy may be reduced to even less than 3 months time. There's a data coming up nowadays that you need not continue for a longer period of time, because many of these patients may be relatively old by age. They have other factors. So the chances of bleeding may increase. So with the newer generation stent, second generation, maybe third generation stent, this long-term dual antiplatelet therapy may not be recommended. However, for high-risk individuals with diabetes, chronic kidney disease, and multiple site atherosclerotic disease, a continuation of a heavy risk factor, longer duration of the disease process, very high density of atherosclerotic arterial disease may need a longer period of dual antiplatelet therapy, maybe for more than 1 year up to 2 years. Patients having associated atrial fibrillation may also require triple therapy, but there is a guideline which has to be followed, that how long and what kind of drug therapy has to be given to them. Of course, triple therapy is not given for a longer period of time. For a short period, you give triple therapy and then you discontinue one and continue either aspirin or clopidogrel along with something like NOACs. I sometimes prefer clopidogrel with NOAC because aspirin has got some kind of GI bleeding problem. Clopidogrel somehow has got less GI bleeding problem. One has to remember that. Anyway, thank you very much for your attention.
Sir, I would like to compliment you for an excellent talk, touching upon the so many factors which we learned, like lifetime ASCVD score, DAPT scoring, and the guidelines based for the use of DAPT, and so that doctors can individualize the therapy and all. Sir, I do have couple of questions. Probably these questions are more of practical questions, so I would like to ask them with the doctor's name as well. A question from Dr. Sanjeev. In
Right.
ACS patients, what is the right dose of aspirin, clopidogrel, and statins before shifting to the higher center, probably for revascularization or so?
It's a good question. Once you know that, firstly, that you do not know the condition of the patient, that whether this patient is going to go for intervention or the patient may have severe extensive triple vessel disease. If it's a STEMI patient, like acute coronary syndrome, if it's a STEMI or non-STEMI, if it's a STEMI patient, definitely patient is going for intervention. Then the dosage recommended, if you go for clopidogrel, the dosage recommended is 600 milligram loading dose of clopidogrel. Aspirin recommended dose is 150 milligram, that's what I give. And statin is 80 milligram. That is a recommended dose before you transfer the patient. But if the patient is acute coronary syndrome, but the troponin and other enzymes are not elevated, so it could be unstable angina. Patient has history of smoking, diabetes, and other risk factors. And let us say patient is some 65 years of age. You do not know. The ECG doesn't tell us anything. We cannot really find out the location of the blockage or anatomy of the coronary artery. So if you think that this patient after angiogram may have to be stabilized with medicine and eventually has to be subjected to bypass surgery, they do not load the patient with clopidogrel or prasugrel because it binds the platelet irreversibly. Then ticagrelor would be a better option. If you contemplate that patient may require bypass surgery after the angiogram, then probably I would recommend not to give. So I suggest clopidogrel is fine, but prasugrel, no, prasugrel has to be given once you are committed for intervention. Otherwise, ticagrelor is safe, ticagrelor you can give. But clopidogrel to be on the safer side because there is less chance of bleeding and very time-tested P2 Y12 inhibitors. That's a good drug, and statin has to be atorvastatin recommended dose 8 mg.
Same second part of this question, sir. Whether ticagrelor can be used in post-MI patients who has undergone coronary intervention. Probably maybe he's asking maybe at the second drug or the third drug.
Right, I think I mentioned that ticagrelor can also be used. This is the reasons why ticagrelor. I also use ticagrelor, but in those, the advantage of ticagrelor is both advantage and disadvantage. Advantage is that it is reversible. So therefore, if you think that patient may need bypass surgery, then you can actually stop the drug just for a few hours, maybe 6 to 8 or maybe 10 to 12 hours, and the patient can be taken up for surgery. Advantage. Disadvantage is compliance. It has to be given twice daily. So that is one problem that ticagrelor has. Third is ticagrelor sometimes causes shortness of breath. Ticagrelor also is known to cause a little bit of bradycardia. So these are the things one has to remember. Otherwise, it's a good drug. There is no doubt about it. And we are getting a good experience of ticagrelor now. I'm a for ticagrelor, but clopidogrel also was a very well tested, time-tested drug.
Sir, a question from Dr. Abhishek. What's the role of statins in the management of peripheral arterial calcification? What is the normal treatment modality in such patients?
Right. The answer to the question is that once you get a peripheral arterial calcification, once you get an arterial calcification, that is an evidence of atherosclerotic disease. So it's an atherosclerotic peripheral vascular disease. So since it is an atherosclerotic peripheral vascular disease, we have to give statin, no doubt about that. But one has to remember, after the statin does not abolish the calcium. Calcium basically a degenerative process by which the plaques are being fixed by calcification, which is a degenerative process. But what atorvastatin does, it stops the further progression of the atherosclerotic plaque. One, B, it also stabilizes the plaque. Therefore, the atherosclerotic peripheral vascular disease are also known to have peripheral arterial thrombosis that can be prevented with your statin therapy along with antiplatelet drug. Remember, even peripheral vascular disease patients also require antiplatelet drugs like aspirin, clopidogrel. These even sometimes use silestazole. These are very useful drugs for peripheral vascular disease.
So a question from Dr. Sanjeev. What is the highest dose of statins in ACS patients with diabetes, especially in Indian set of patients?
Like highest dose of statin in the sense is it chronic or acute?
Acute, sorry, ACS.
ACS. The dose recommended is 80 milligram to start with. And then you start with 80 milligram and see that since it is ACS, patient is going for some procedure. Let us say you stabilize the patient. If you feel that patient is doesn't need immediate intervention, there is a scoring system by Gray score and so many other scores. If you think that patient does not need immediate intervention, you can hold on for a couple of days. Pre-hospital, you can do an angiogram, and then you can do an intervention. But the dose recommended is 80 milligram. After 80 milligram, keep the patient on follow-up. Because the reason 80 milligram, one, at a higher dose, atorvastatin also is very good as an anti-inflammatory agent. And acute coronary syndrome is also an acute inflammatory process. It has been said that high dose of statin also act as an anti-inflammatory agent. So you give high dose of statin, then on follow-up, you see the patient's clinical status, how the patient is doing, if the patient is fine, and the cholesterol level has already been achieved, then slowly reduce the dose from 80 to 40. And then in the third follow-up or the second follow-up, again you check cholesterol and see the clinical status. If you find the patient is further improving, cholesterol has not gone up, it is actually coming down, you reduce from atorvastatin from 40 to 20. And then probably between 20 to 10, you have to play around and see how the patient is doing. And then you continue the dose at which the patient, because there is a target LDL, which is already there for that particular patient from the risk of the patient. Once you achieve that target, for that particular patient, as I shown in my last but one slide, that whether the low, intermediate, or high is what group and what is the target. If the target has been achieved, then you maintain on that dosage.
So very good question from Dr. A.K. Das. Patient on warfarin, whether he requires antiplatelet therapy and what are the therapy that he would require?
Right. This is a good question. Firstly, one has to understand that warfarin and antiplatelet drug, they do not act at the same site. The mechanism is completely different. Warfarin is a vitamin K antagonist, right? Whereas antiplatelet drug, they act on P2Y12 receptor, which is a receptor situated on the surface of platelet. But vitamin K antagonist warfarin doesn't act on platelet, it acts on the coagulation cascade. That's the extrinsic pathway of coagulation cascade. At that cascade, warfarin acts. So warfarin is indicated in those situations. For example, somebody, let us say, already having atrial fibrillation, right? And the patient is also developing acute coronary syndrome. So what you need to do, patient was on warfarin, but then if the patient is on warfarin and patient has to go for some intervention and the patient is coming on an elective basis, you discontinue warfarin for some time. And after that, maybe it takes time, it takes something like about 2 to 3 days. Then you monitor the INR. And if the INR comes below the therapeutic range, which is something like less than 2.7, around 2.5, then you are comfortable. Then you can start the procedure. In an acute setup, this is a big challenge. It's not that easy. You have to take all precautions. You may have to actually require vitamin K as well. So that is the role of warfarin. For atrial fibrillation in general, along with coronary artery disease, these days we got a NOACs, something dabigatran, apixaban, rivaroxaban. It's a good drug. Then we need not monitor them. But again, there is a little higher chance of bleeding. One has to remember that. But then, if your patient is already on that, you can do the procedure. After the procedure, you have to titrate the dosage. In those situations, I will not recommend to go for prasugrel or even your ticagrelor, because ticagrelor and prasugrel has got a relatively higher bleeding incidence as compared to clopidogrel. So clopidogrel is probably clopidogrel, aspirin 75 milligram, clopidogrel 75 milligram, and NOAC according to the recommended doses. Maybe apixaban 110 milligram BD, apixaban 2.5 milligram, 5 milligram to start with 2.5 milligram, rivaroxaban 20 milligram followed by 15 milligram, or dabigatran 110 milligram twice daily. Then after initial, maybe for about 1 month, 2 months time, you titrate the dose, get rid of one of those. Maybe 3 months. That is the time. 3 months time to get rid of one of those. Maybe you can take off aspirin and continue clopidogrel and NOAC. That is my recommendation. If you think that patient is better off with warfarin, then warfarin and only one antiplatelet drug. Don't give 2 antiplatelet drug along with warfarin, because you are increasing the chance of bleeding in those patients.
Sir, a question from Dr. S.K. Panda. Patient with diabetes, hypertension, and CKD who is on dialysis, what would be the management of lipid, and what statin can be given, and probably what's the creatinine level which we need?
This is a good question. Firstly, this is a case which is a relatively high risk group of individuals. If you stratify them, this is a relatively high risk group. So high risk group, because chronic kidney disease itself takes a patient to a higher risk of atherosclerotic process. We know that. So these group of patients would require a higher dose of atorvastatin. Now, we cannot say that whether the patient would require 80 milligram or 40 milligram. Difficult, because there is so much variation from patient to patient. So probably to start with, depending upon the lipid profile, if the LDL is very high, let us say 190 milligram, of a patient where the creatinine is high and patient is on dialysis and other factors. Patient is on dialysis, so creatinine doesn't matter much because you are doing dialysis anyway. Patient has diabetes and other factors. You start as a 80 milligram and monitor the lipid profile. As the lipid profile improves, then you slowly reduce the dose from 80 to 40 milligrams. But probably this group of patients would require a relatively higher dose of statin that has to be adjusted according to the patient overall risk and the response of that particular patient to the dosage that you commenced.
Sir, and Avijit wants to know how low one can have a LDL levels, how much one should lower it, and also is there any isolated low HDL?
Right. No, this is HDL. HDL, as I said, somehow this South Asian population has a relatively low HDL. This is the observation. But low HDL alone, so let us say everything else is normal. LDL cholesterol normal, non-HDL is also within normal range. And then HDL is, let us say, low, something like, say, 28. That itself will not cause atherosclerotic cardiovascular disease. Chances of developing atherosclerotic cardiovascular disease is high, is very low, is definitely low. But again, as someone where LDL is high, let us say LDL is say 150 or 170 milligram, a triglyceride is about 180 milligram, and HDL is low, say 30 milligram, and that patient has diabetes. In those patients, the chances of having very aggressive atherosclerotic cardiovascular disease is very high. In those group of patients, the low HDL-C probably plays some role. Problem is that the literature and the physician, the research people, they tried a lot to enhance the HDL level by various medication and other kind of thing, niacin, and so many drugs. Came to the market, and nothing actually has been found to be extremely useful by our randomized control trial. But probably if you exercise regularly, if you can maintain a body fitness, that is helpful in enhancing the HDL level. HDL may also have some contribution from the family, because I have seen many families, they have got a well-protected coronary arteries because of relatively high. I know quite a number of families where the HDL level is more than 45, and they are actually absolutely fine. Incidentally, many of those members in that family, in those families, they don't smoke, they don't have diabetes, which is again a good thing.
Sir, how low that LDL level can be?
LDL level. LDL actually I've already shown in my slide, because what happens is, how low is nothing like that.
Okay.
Again, you categorize that what kind of risk that patient has. Low risk, borderline risk, moderate risk, high risk, very high risk. Now each risk, that last but one slide has clearly shown that every risk has got a target LDL cholesterol, right? So if you have very low risk, say the target is 116 or maybe 120, you should be happy. You don't need to give any tablet, lifestyle modification. But if you got a high risk, then your target is 50 or 55, then you should be given more intense statin therapy, 80 milligram. Patient may not respond to 80 milligram. Then you add ezetimibe. Patient may not respond to that combination. Then you add PCSK2 inhibitors. So that is the way. You have to maintain the target of LDL cholesterol. Target is not constant. It is not how low is the low. That, I remember about 10 years ago, or maybe I would say 20 years, 2002, 2005, the lower the better. That kind of idea is slowly going, because now we categorize the patient to various risk group, low risk, intermediate risk, high risk, this kind of thing. And accordingly, we target a dose and ensure that patient achieves that dose with a kind of a drug that we prescribe.
Okay. Sir, very good question. What is the role of saroglitazole in diabetic dyslipidemia with hypertension?
Say it again?
Saroglitazole.
Oh, that is a different thing. That people are prescribing, and there is some benefit, but literature is not very vocal about it. There is some sort of data, but not a very large number of patients are enrolled in such kind of trial. So I do not have much experience. I have some patients on saroglitazone, but again, I do not know. Answer to that question is, honestly, I don't know.
Is this for only triglycerides, sir? If the triglycerides cannot be controlled?
It may be the triglyceride alone, but I have to say that there is no data to suggest that elevated triglyceride can enhance the atherosclerotic process alone. Because elevated triglyceride, to cause high atherosclerotic process, the triglyceride has to be very high. One. Second, one also has to remember that atorvastatin, even rosuvastatin, can also reduce triglycerides.
Okay. Sir, question from Dr. Subrata Das. If there is a hepatic dysfunction, suppose the SGPT is more than 5 times the normal levels, what should be the starting dose of statin?
No, firstly, that's a good question. If the SGPT is very high, and you find out that this patient, there must be some intrinsic liver disease. So it's just not SGPT. You have to check the entire liver function. It is very unlikely that SGPT has gone 5 times more than the normal value, and everything else of the liver function is normal. Very, very unlikely. You need to know the prothrombin, serum albumin, bilirubin, Hg, OT, alkaline phosphatase, the entire liver function you need to know. And I'm sure that if the HGPT is 5 times high, there will be some abnormality in other areas also, in other parameters also. You need to investigate that by doing ultrasound and other investigation as being suggested by hepatologist or gastroenterologist. The problem is that HGPT, if let's say is marginally high, then the problem comes because everything else is normal. Patient does not have any established liver disease clinically, or even sort of no investigation has been done, or by ultrasound there is a hepatomegaly and this looks okay. But HGPT is marginally elevated. Then what do you do? What patient has got an atherosclerotic cardiovascular disease? The suggestion in that case is you start small dose of statin, something like 10 milligram of atorvastatin. That's what I do, or 5 milligram of rosuvastatin. Give for about a month. Monitor just for about 10 days time. You ask the patient to come back with a repeat liver function test report. If you find that HGPT is progressively going up, then you should investigate for the liver disease. And maybe you can reduce the dosage of the statin that you prescribe. For example, if someone is on atorvastatin 10, you reduce to 5 milligram. If someone is on rosuvastatin 5, you switch over to atorvastatin 5. That seldom happens. B, that if you find that the dose is same, then you continue the dose and ask the patient to come after about another 15 days time and see the liver function test. If you find that it is not actually going up, it remains the same, there is no change, but the dose required for that particular patient from cardiovascular point of view is relatively high, then you switch over from 10 milligram atorvastatin to 20 milligram atorvastatin and follow the same protocol. That is the standard recommendation.
So, question from Dr. Susanta. If we suspect a patient posted for a primary PCI, likely to have a TVD or left main disease, is it not wise to load with ticagrelor instead of clopidogrel, as the patient is taken for CABG and ticagrelor has a shorter half-life?
I think I answered that question very clearly. In my talk also I mentioned, again I answered the same question, that if one suspect that after angiogram the patient may be a candidate for bypass surgery, then do not load the patient with clopidogrel or prasugrel. The choice of antiplatelet drug is ticagrelor, because one, it is reversible, B, it is short lasting. So therefore, after about 10 to 12 hours time, patient will be fit enough to go for bypass surgery. It's very clear. There is no confusion about it.
Okay, sir. Same again, Dr. Subrata. How long should high intensity statin be continued in post CVD with DM, diabetes mellitus?
Say it again, post
PTCA case
right.
of TVD with diabetes mellitus.
Right. That is triple visual disease, diabetes mellitus is a high risk group. In those situations, the high intensity statin should be continued at least for about, I would say at least for a month. And after a month, you repeat the lipid profile and see what is the lipid level. Normally, it comes down significantly. As it comes down, you reduce the dose from 80 milligram to 40 milligram, provided during this 1 month time, patient do not have statin intolerance, like muscle pain or even hepatic enzyme elevation. If these things are there, then you have to reduce, you have to talk to the patient, explain to the patient, in case you get muscle pain, you contact me or you come to me, then we may have to reduce the dose of statin. But if these things are not there, then you continue for a month. After a month, you monitor the lipid profile, and the lipid profile shows significant reduction of LDL-C. Then you reduce the dose from 80 to 40. And then you continue for a longer period of time, maybe for 3 months. By the time everything settles, and after 3 months, then probably whatever is the target, depending upon his risk factor, that has to be continued. It's already 6:15. How long?
Yes, sir. I think we are done with the questions, and I think our audience are very happy because you have given most the practical tips for managing the cases like ACS or CABG and all. I think we will conclude the session. Just a minute. I'll call Pankaj. He'll just give a vote of thanks, sir.
Sure.
Pankaj.
Thank you, sir, for your long session. And we sincerely thank you, sir, for your excellent scientific deliberations. Myself, Pankaj Kumar Patel, sir. I'm from Ajanta Pharma. And Ajanta Pharma is among the top company in cardiology in India. We focus on many innovative and combinations first time in India. AtorFit CV is one of them. And we are consistently committed to our bringing our scientific deliberations to the doctors, sir.
Excellent, Pankaj. Is nice to, but only Tripathi comes to me. I don't know the other people of your company. Tell others to contact me.
Sir, he will be there. He is there, sir, already. And
Tripathi looks after AtorFit CV.
Yes.
Yes, sir. Yes, sir. And sir, there are a good number of delegates are also there. We are very much thankful to all the delegates who have joined in spite of their tough time and this tight schedule. We also thanks to our field team and HO team who have made this program successful. Special thanks to Dr. Veena. And have a great time.